Dr. A, welcome to the show. How you doing?
I'm doing fantastic.
It's so great to have you.
Thank you for having me.
Of course. I'm a fan of your podcast. You guys you put out excellent work, and I'm excited to get into the topic of your expertise, PCOS, endometriosis, topics that I know nothing about.
I love it.
It's my favorite episodes to do, actually.
Oh, really? I love talking about PCOS and endometriosis. As you know, both together are the leading cause of infertility in women. And majority of women go through life and they're not diagnosed. How about that?
It's crazy. Before you came in, I learned that approximately 6 to 12% of women of reproductive age in the U.S. have PCOS.
More than that.
More than that.
15%.
15%.
Yeah.
And roughly 1 in 10 or more globally.
Yes. Because if you go to Middle Eastern countries, that number goes up.
It shoots up.
Probably with insulin resistance, genetics.
Wow.
Yes. And yet, women go through life. 75% of PCOS patients are not diagnosed. I think that number is a lot higher. And same thing with endometriosis. I think 20% of women have endometriosis. And majority of them go through life and they're never diagnosed.
Okay, so this is a very important topic, an underserved topic.
Yes.
So let's start with PCOS. What actually is it and why is it so misunderstood?
So PCOS is a hormonal imbalance that is the most common hormonal imbalance in women in their reproductive age. It affects 15% of women. And in order to diagnose it, you need to meet 2 out of the 3 criteria. 1 is history of irregular cycles. 2 is PCOS morphology on ultrasound. This is polycystic ovarian syndrome, doesn't mean cyst in the ovary. People still look for cysts. It's a specific finding on ultrasound, which is dominant follicles. And these are ovaries. We call it string of pearls or follicles all around the edge of the ovary on ultrasound. It's a very specific finding, and that's criteria number 2. And criteria number 3 is symptoms of elevated testosterone. What are we talking about? Hair loss, facial hair, body hair, acne, body acne. And you don't have to have a high testosterone in the blood to get the diagnosis. So you need to meet 2 out of the 3 criteria. And that's why there are so many different presentations of PCOS. One can have normal regular cycles with PCOS looking ovaries on ultrasound and high testosterone symptoms. The other one could have irregular periods and no testosterone symptoms. Do you know what I'm saying? So there's so many different combinations of these patients presenting. 70 to 80% of PCOS patients have insulin resistance. 75% of them gain weight. These are women who say, I exercise twice a day. I'm not eating anything. I'm killing myself and I can't lose a pound. And my skinny friend eats whatever she wants. She's not exercising and she's thin. So weight gain, frustration with weight loss is very common with PCOS patients. Fertility issues, we can go into that, is another issue. Mood disorder, because their hormones are all over the place. These patients are at a higher risk of having anxiety, depression, lack of motivation, irritability. They're more common to have PMS, PMDD. And eating disorders are very, very common. I always say if you want to find PCOS patients, go knock on the doors of these eating disorders where teenagers are sitting at, and you'll find all the PCOS patients. So these are patients who get frustrated with their weight. They have the anxiety, they have the mood disorder, they're gaining weight. They do everything in their power to lose the weight and they can't. And their hormones actually stimulates this binge eating craving. So they start binge eating, but instead of someone addressing their metabolic health, where do they end up? With the psychiatrist, right? In an eating disorder center. And it's really, really sad. So if there's one thing I would change, I would love to bring awareness to this. I would love to go knock on the door of these eating disorder centers and pull those girls out and treat them.
Wow. Now, is it the eating disorder, how is that causally related to PCOS? Like, is it?
So you have to understand PCOS in order to understand why these symptoms present in these patients. If you look at PCOS, at its core, it's a brain-ovary axis issue. What does that mean? We have a part of our brain called the hypothalamus, which releases a hormone called GnRH. I don't know how much you want me to go into this,
Please, go into
I
it
want to
all.
go
Yeah,
into it
yeah.
because patients need to know what's wrong with them.
We don't shy away from science.
I love
podcast.
it.
Yeah,
I
we love
it. Some people don't want to know the science. So basically, this hypothalamus releases a hormone called GnRH. This GnRH usually secretes in a pulsatile fashion and controls two hormones in the pituitary gland, FSH and LH. FSH stimulates follicles in the ovary to grow, and LH comes mid-cycle surge, and when it gets secreted, the follicle ovulates, right? So the FSH and LH control the follicle growth and ovulation in the ovary. That's why the brain-ovary axis. What happens with PCOS patients is that their GnRH, instead of secreting in a pulsatile fashion, it starts secreting really, really fast. And when the brain starts secreting GnRH super fast, what happens is the pituitary gland shifts the secretion of LH and FSH and starts secreting more of the LH. Now, the LH was the mid-cycle hormone that was supposed to come for ovulation. When you have constant secretion of LH from the pituitary gland, it stimulates the theca cells in our ovaries to release testosterone. Every month, our ovaries, certain number of follicles from antral follicles get recruited to come up that month, and they grow with the FSH that comes from the brain, and these follicles grow until one dominant follicle keeps growing, and then we get a mid-cycle LH surge because these follicles secrete estrogen. So the estrogen feedbacks into the brain to give a surge of the LH. When the LH comes, this one follicle that was the dominant follicle ovulates. What happens with PCOS patients, because this testosterone is being secreted by the theca cells, testosterone is toxic. Imagine testosterone being toxic to these follicles. So these follicles stop growing halfway, they get stuck, and ovulation does not happen, right? So now you have an inflammatory environment with all these follicles that are stuck in the ovary. There's no ovulation in majority, 70 to 80% of PCOS patients have insulin resistance, and a lot of them have issues with ovulation. Even PCOS patients with regular cycles, those are not necessarily ovulatory cycles. They could be withdrawal from estrogen, which it's too complicated and I don't need to get into it right now. But what happens is these PCOS patients now are not ovulating regularly because of this toxic environment. So this vicious, and then androgen secretion stimulates more of the GnRH secretion from the brain, and then you have this vicious brain-ovary axis loop that's happening, pumping testosterone out. Are you with me so far?
Yeah.
Now, so that's the first vicious loop that causes elevation of testosterone. What does testosterone do? Causes irregular periods. We're not ovulating. Facial hair, body hair being the most common symptoms. Acne that does not respond. These patients end up doing Accutane because nothing works for them. And they have hair thinning at a young age. Why would a 25-year-old have a lot of hair loss? But these patients get dismissed. So you have all these high testosterone symptoms because of this vicious loop. Now, 70 to 80%, this is the part you're going to love, 70 to 80% of PCOS patients are insulin resistant. But what does that mean? I'm sure you know what that means.
Please share.
But when we eat carbohydrates, our body breaks it down into glucose. Glucose stimulates our pancreas to release a hormone called insulin. The job of insulin is it goes to the receptors on the surface of our muscles, opens up these receptors, these channels that basically grab the sugar from the blood, push it into the cell where it turns into energy. This is what's supposed to happen. But PCOS patients usually have family history of insulin resistance, diabetic family members. A lot of times on the paternal side, there's overweight family members, insulin resistance, diabetics, pre-diabetics, women with gestational diabetes. Somewhere in their DNA, there's some insulin resistance. So when these patients have carbohydrates and their body breaks it down into glucose, and their glucose stimulates their pancreas to release insulin, their tissue is insulin resistant. So not all the sugar can go in. Sugar stays in the blood and causes a large insulin spike. This insulin spike does several things. Number one, it stimulates the liver to take this sugar, in a simple terms, and store it as fat. The fat that you store with insulin resistance is a highly inflammatory visceral fat. So this visceral fat is very different than the fat under our skin. It can be extremely inflammatory, and with that inflammation comes all these other issues. Number one, the high insulin spike lowers the production of a sex hormone binding globulin from the liver. What is sex hormone binding globulin? This is a protein that grabs onto the free testosterone in our blood. So when you have enough sex hormone binding globulin, your testosterone levels are not high. So now you have that first vicious loop that's pumping testosterone in the blood, and then the sex hormone binding globulin that grabs to these testosterone, that's low. You're making visceral fat. But the worst thing that happens is that even though PCOS patients are insulin resistant everywhere, they're insulin sensitive in their ovaries. What does that mean? This insulin spike stimulates the ovary to secrete more testosterone.
Wow.
Okay, so now you have this second vicious cycle of metabolic dysfunction, insulin resistance, that's amplifying the secretion of testosterone from the ovary, that's making the environment for those tiny little follicles toxic, and it's blocking ovulation. Make sense?
Yeah, and that's why, in the setting of insulin resistance, an otherwise totally objectively healthy food can cause, blood sugar to peak higher and to stay elevated longer, which is going to cause subsequently more insulin for a longer duration, which is probably compounding these effects.
And the other thing that this high insulin spike does, sometimes it crashes their blood sugar, right? Because of that spike that you get in the insulin. And when it crashes their blood sugar, cortisol gets secreted, they get cranky, they start craving more sugar, and they crash at 2 p.m. In the afternoon. So that's the second loop. And the third, I call these my Aliabadi pillars or my Aliabadi loops. But the third thing that I see happening in these patients is inflammation. So we talked about the visceral fat that causes a lot of inflammation. High insulin causes inflammation. The testosterone, the ovarian environment, all of these cause an inflammatory process in the body. So then these patients complain of inflammatory changes. They get bloated, they don't feel good, they're tired, they have brain fog, their mood is not good, all of it. So this is the third inflammatory loop that happens. And the fourth one is a psychological one. And I think it goes back to your first question. So what happens in our brain? We have a limbic system, which is our emotional headquarters. Right? All of our emotions are in there, whether it's good, bad, scared, happy, fear, all of it, anxious. This limbic system, which is the amygdala, hippocampus, and hypothalamus, this limbic system needs high levels of progesterone because progesterone has a calming effect on the brain, normal levels of estrogen, low inflammation, and low testosterone. What do we have with PCOS? High inflammation, high testosterone, low progesterone, because when you don't ovulate, right, the progesterone is down. And then you have these follicles secreting erratic amounts of estrogen, right? And these patients are also overweight. Our fat cells produce estrogen too. So all of that causes this limbic system to go on fire, right? And what happens? Anxiety, depression, irritability, mood changes, bad PMS, PMDD, binge eating, cravings, eating, like the eating disorder, really, part of it is that, a lack of motivation. They just don't feel well. Fatigue, they just feel terrible. They're anxious, they're depressed. It affects their self-esteem. They're gaining weight. They have acne. They have facial hair, body hair. No one can fix their symptoms. They're not feeling good. And then you have this limbic system on fire. There is a prefrontal cortex, right, which is the brake on our limbic system. It controls all of our emotions that come out of the limbic system. This prefrontal cortex also needs low inflammation, low testosterone, normal amounts of estrogen and progesterone. It needs good sleep, which PCOS patients don't get good sleep. It needs low cortisol, which PCOS patients have high cortisol. And there are certain vitamins like vitamin D, omega-3, iron, ferritin, all of these affect this prefrontal cortex. So now you have this limbic system on fire, and the prefrontal cortex the brake doesn't work, right? So all these emotions are coming out. They're having issues in their relationships with their parents. They're angry, especially their PMS and PMDD before, their cycles can be very extreme. They're gaining weight. They have an eating disorder. They're binge eating. They have scars on their face because of their acne. Their periods are completely unpredictable. And what happens to these patients? They go to the gynecologist. They go to their primary care. They go to the endocrinologist. And majority of the time, they're told, eat less, exercise more. There's nothing wrong with you. How about that?
That can be frustrating. This does not sound like a walk in the park. That's why I'm so glad that you're here to deliver such empowering information to us. I'm heartened by the fact that you said such a large proportion of cases are due to some kind of like lifestyle or environmental factor. Because to me, like I'm thinking about this through an evolutionary lens, like to the extent that it negatively impacts fertility, which you described. I'm like wondering how evolution selected for this. Like what proportion is nature versus nurture? But you've said like, the majority of cases are either due to some like, whether it's overweight, obesity, insulin resistance. I mean, these are all like heavily environmentally mediated.
And I want to talk about the lean PCOS patients because 25% of PCOS patients are thinner than me, right?
So what explains that?
So these patients, if you take a lean PCOS patient and put it next to another lean woman, same height, same weight, same diet, same exercise, 60 to 70% of women with the PCOS, lean PCOS, have tissue insulin resistance. And sometimes during pregnancy, we catch them because we load them with a load of sugar and then check their blood sugar, or they become diabetic and the doctor's scratching their head, why is this patient diabetic? But they tend to be less insulin resistance, and the lean PCOS patients have more of that first brain ovary axis loop that I was talking about. But even lean PCOS patients at their tissue level, 60-70% of them still have insulin resistance. So I don't want to forget about these patients, because if you're thin and you have irregular period and you have acne and facial hair, and based on the criteria, you meet the criteria for PCOS, they go to the doctor and the doctor says, well, you're not overweight, so you don't have PCOS. Well, 25% of them are lean and they don't have any weight issues. But they still have an eating disorder because all the inflammation, all the hormones, all of it is still there. So you can have lean, you can go to these eating disorder centers and pull out lean PCOS patients that have irregular period, acne, facial hair, body hair.
Well, but that doesn't mean that for those patients that there was no environmental factor, right? Like
Always.
Being normal weight is not a guarantee of metabolic health.
Correct.
You have normal weight, metabolic obesity, you have TOFI, thin on the outside, fat on the inside.
Yeah.
So, I mean, it's still, even in those cases can be likely traced back, I'm assuming, to environment.
To environment, to the food, to the exercise. But you know what? There are patients who are trying their best and they're really eating healthy and they're exercising and they're watching their diet. We just did a podcast with Ashley Holm, and by the time she got to my office, the makeup artist, you probably don't know.
I don't know.
She don't wear makeup. She's a celebrity makeup artist. I love her. And she was talking about how she had seen so many doctors. By the time I saw her, she must have been 32. And she was depressed. And, it affects everything. It affects your mood, your self-esteem, everything. And because, when so many doctors constantly tell you there's nothing wrong with you, it's in your head, after the 15th time, you're going to start believing them and you're going to start thinking you're crazy.
So is this a solvable problem?
Yes. That's why I want to go to these eating disorder centers. I want to catch them when they're young. The issue with the diagnosis of teenagers, you have to be very careful, and I want to address it here. is that teenage girls, you cannot use the ovarian morphology as one of the criteria. So in order to diagnose a teenage girl with PCOS, they need to have the irregular periods and they need to have elevated testosterone symptoms or high testosterone in their blood. That second ovarian morphology you can't use because teenagers have tons of eggs, and that can be confusing. But even if you don't diagnose these, I don't like diagnosing teenagers with PCOS, but I do treat them. I address their issues. If they're gaining weight, I'll address that weight issue. I address their metabolic health. I address the importance of diet and exercise. I might, so you have to address these things. And to tell you how you can, first of all, you have to diagnose PCOS patients. And one thing I did because of this frustration over the years, I have a platform, I don't know if you know, it's called OVII.com.
I don't know, but
it's a PCOS supplement so basically if you go on OVII.com, I have a calculator free of charge. It's out there. I ask all the questions I ask in my office, and a very smart computer science guy helped me do the algorithm. And basically with my calculator, I can tell you the likelihood of you having PCOS. I cannot diagnose obviously on a website, but I can tell you if you have a high likelihood, or you're less likely to have PCOS. Let's start there. Because majority of these patients are not being diagnosed, even when they end up in a fertility clinic, they're still not being diagnosed. They have to be their own health advocate. I'm here today to tell you, if you're listening to this podcast and your periods are irregular, or if you have symptoms of high testosterone, if you're gaining weight and you cannot lose the weight, if you have mood disorder, if you have bad PMS, if you're anxious, if you're depressed, if you have any family history of diabetes, if you have any of these, if you have fertility issues, make sure that you don't have PCOS. Go on OVII.com, take the test. Now, I created this supplement, again, because these patients they never get diagnosed. I cannot prescribe medication, obviously, online. One of the first things you want to address is their metabolic health, that main loop that amplifies this testosterone secretion from the ovaries and causes havoc in the body, really. So in order to address that, usually I used to give literally 10 different supplements. Take inositol, take this, take that, take curcumin, vitamin D. So I created this supplement that has everything, is 16 ingredients, basically addressing the pillars that we talked about. The first pillar is heart because it's a brain-ovary axis, but this supplement deals with the metabolic health issue because that's at its core. You have to fix, you're the god of this, but you have to fix the underlying metabolic dysfunction. And it has reducose in it, which basically if you take it before your heaviest meal, especially for patients with weight issues and insulin sensitivity, it blocks the absorption of carbohydrates by 42%. It has inositol blend in it with vitamin D and other supplements that make patients insulin sensitive at tissue level. Again, when we are dealing with insulin resistance, you want to make it easier for the sugar to go into the tissue. So these supplements have, each ingredient has years of data behind it.
Well, what about weight loss? Weight loss is one of the most effective
We're going to talk about that.
Yeah.
I love that. So the reducose in the OV can help them with their weight loss. It can make them insulin sensitive, and it has a lot of antioxidants for that inflammatory pathway. So that's the first line. I want to finish the treatment so these patients who are listening, they can understand it. So I always start with the supplement. But another prescription medication that we use if diet, exercise, and healthy lifestyle is not working is metformin. Have you heard of metformin? Yeah. So metformin helps with insulin sensitivity, and the minimum dose for these patients is 1,500. So a lot of times doctors give them 500 milligram, and the patient's like 300 pounds. It's not going to touch the patient. So in addition to OV, I add metformin. Now, in 2014, I know you probably won't believe me, but in 2014, I was using GLP-1s for my PCOS patients.
Yeah, I would think that the new wave of GLP-1 drugs would have supplanted metformin as a first line.
So now it is, but back then in 2014, I only had Trulicity. Have you heard of Trulicity? It was a diabetic medication. It was not for weight loss. I wish I had thought of like something then. It would have blown up because I literally used it for years before it blew up in this country. So Trulicity, I would add after, back then I didn't have OV. I would give him all these little supplements to take. I would give him metformin. If metformin failed and they needed to lose a lot of weight, I would give them Trulicity, which was a weekly shot. After Trulicity, we had Victoza, then Saxenda, then Wegovy, Ozempic and Wegovy, and then we got into tirzepatide. So these medications, literally, even Trulicity in 2014 for my PCOS patients, was like an oxygen mask on their face. Why? Because these GLP-1s address that insulin sensitivity. They make patients insulin sensitive. They help regulate the insulin. So it only spikes when you eat. It doesn't stay up all day. And as a side effect, it has delayed gastric emptying and it curbs their appetite. So really, even in 2014, I had patients losing 60 pounds, 50 pounds on these medications, and it's really life-changing. I don't know if you remember, but when the Ozempic blew up a few years ago, people were like, this is a miracle drug because I used Ozempic and I got pregnant. Why do you think? These are PCOS patients, not diagnosed. They address their insulin resistance, their testosterone level goes down. As testosterone goes down, they start ovulating and they get pregnant.
It's pretty awesome. I mean,
Isn't it crazy?
I'm glad that we have them for people who've just spent a lifetime of yo-yo dieting, but also like, if you want to raw dog the weight loss, I mean, that's effective too, is it not? I mean,
that's the first line.
Lose body fat.
So that's the first line. And one of the things that is so important with PCOS patients, and I talk to them, is you treat them just like you do with diabetics. What do you tell diabetics? When you eat food, go walk. First of all, watch what you're eating, but go for a walk immediately after eating, because when you walk, what do? You're using your muscles and you're pulling that sugar in. So you lower that insulin spike. These are little steps that every single person can take on a regular basis. When we go to medication, I assume that all of these things are already checked. But I'm here to tell you that there are women who struggle. They do all this. I have literally patients who say, I cannot possibly eat less. I do these diet programs. I eat 500 calories a day. I'm exercising with a trainer twice a day, and I just cannot lose it. PCOS is a very, very complex condition. And because these patients present in so many different ways, doctors are confused. They don't know how to diagnose these patients. That this one person is skinny, the other one is not. One person has acne, the other one has facial hair, body hair. One has regular period, the other one doesn't. One has eating disorder, the other one doesn't. And just all the symptoms that we talked about, imagine combining different combinations of these. And that's why it's so hard. It shouldn't be hard, right? I already told you need to meet 2 out of 3 criteria. Anxiety and weight and all of these things are important, but the main criteria are the irregular cycles, the PCOS morphology on ultrasound, and symptoms of high testosterone. That's it. You need to meet 2 out of 3. You can walk around after this podcast, you're gonna go to Starbucks and you're gonna say, wow, this woman has PCOS. You're gonna you can pick him out of a crowd.
Why do some women have cysts and others don't in their ovaries?
So polycystic does not mean cyst on the ovary. So you don't have to do an ultrasound to look for a cyst. And that's what doctors do to this day. They do an ultrasound, they're like, you don't have a cyst. Remember I told you the follicles freeze in the ovary depending on your metabolic health and everything else. Some women, not all PCOS patients have this PCOS-looking ovarian morphology that you see a sac of pearls, like all these stuck follicles in the ovary. And there are some normal women without PCOS who have PCOS-looking ovaries just because genetically they have so many eggs. So that's why you need to have these other criteria. You can't just go by the ovarian morphology, and definitely you can't use the ovarian morphology for teenagers. But it's not a cyst, it's their follicles.
Interesting.
Now, 40% of PCOS patients, in my opinion, also have leaky gut or gut issues. They complain of bloating, they don't feel well. that could be because of all these hormonal shifts in them. PCOS patients, commonly, we see a lot of polyps because when your hormones shift like this, the lining inside the uterus, which is the endometrium, can fluctuate, and you get these growths of endometrium that can eventually form polyps inside the cavity, which for women who are trying for pregnancy, sometimes if you have a big polyp, it'll block you from getting pregnant. So it's important. That's the importance of doing an ultrasound, right? To this day, women go to their well woman exam, and the doctor is just asking for some birth control questions, some STD questions. They do a quick pap breast exam, and the patient's out the door. So unless you take a good history, you're going to miss PCOS. Unless you do an ultrasound, you're not going to be able to look at their ovaries. The problem is, because doctors don't diagnose PCOS because they don't know, they still think the patient has to have a big cyst on the ovary to have polycystic, which is a bad name for this condition. They, even if they do an ultrasound, they can dismiss it. There's so many levels where these patients get dismissed and dismissed and dismissed and dismissed, and that's why, that's why I'm here.
Yeah, no, I love it. But it all kind of like comes back to metabolic health at the end of the day.
Yes.
Which
you should talk about that.
No, I mean, well, we do. I mean, it dovetails with a lot of what we talk about on this podcast, like the recommendations, that I've made ad nauseum for, losing body fat, shifting body composition to a healthier state,
Yes.
building muscle. Like, it seems to me, in my completely novice, non-expert, like as I'm listening to you talk about this, like the recommendations from my vantage point would seem quite similar to those that I would make for somebody just trying to like get fitter and shift
Yes.
their body composition to a healthier state.
Yes, but that should be the baseline. That's the baseline. And then you add the supplement, and then you add the prescription medications, and then you add the GLP-1s. And if you treat these patients correctly, and not every PCOS patient needs to do everything. We treat them differently depending on their symptoms. For example, you can have a lean PCOS patient who has regular cycles and just has acne. For that patient, you can put her on birth control if she needs to be on birth control, or you can just, give her spironolactone to treat her acne. I do give supplements to all my patients because they like the tissue insulin resistance that we talked about. And even lean PCOS patients, exercise is a must. Diet is a must. The problem with GLP-1s, I'll tell you what the problem is. A lot of times it's a shortcut. And patients lose weight without having to exercise or really watch what they're eating. And that's the problem that I see with it.
They can lose lean mass.
Yes, and they lose muscle mass. And so that's a conversation that needs to be done with them. And that's why it's so important and that's why you hear, so-and-so used GLP-1s, lost, 100 pounds, stopped it, and gained it all back because you haven't addressed that underlying metabolic health.
Yeah.
And if you don't do that, you blink and it comes back.
Yeah, my understanding of the etiology of insulin resistance has evolved over the past couple of years and really kind of shifted, actually, more specifically. Like, I think low-carb diets can be effective as like a Band-Aid, like symptom management, because you're reducing the blood sugar spikes, right? Yeah. You're reducing the glucose load. But at the end of the day, I think the best diet is going to be the one that allows you to sustain a calorie deficit so that you lose that ectopic fat. You lose the fat in your liver, you lose the fat in your pancreas, you regain insulin sensitivity. And, that's going to be whatever diet. Yeah, fit, exercise. I mean, exercise leads to insulin-independent glucose uptake.
Yes.
It's also powerful. More people need to know.
And I don't know how much time we have.
We got some time, yeah.
Okay, because I want to hit endometriosis too for you.
Please, let's.
So
what is that?
So one thing I want to talk to you is, and this is, again, my observation, and I've seen PCOS patients for many years. I've been in private practice for 25 years and in women's health for 30 years. In my opinion, and I do a lot of endometriosis surgery, 50 to 60% of PCOS patients have endometriosis. And that's my observation. And I sometimes talk to PCOS experts. They're like, oh, well, I don't know about that. We need to study. No. I'm telling you, I'm not asking you. I'm telling you that there's a correlation. And so whenever I see PCOS, I want to make sure I'm not missing endometriosis and vice versa, because I really think they go hand in hand.
What is that? What is endometriosis?
So endometriosis, again, one of the leading causes of infertility on the planet. is when tissue similar to the lining of the uterus. I wish I had brought my model so I could show it to you.
Oh,
it makes it so much.
Next time.
Yeah, you need a model of uterus here.
We do, yeah.
Next time I'll bring it for you.
We
as a
need
gift.
many things, but you live here in LA, so we'll have you back.
I'm going to deliver it to you. So if you think about it, every month our ovaries secrete estrogen and progesterone, basically to get the lining inside the uterus called endometrium ready for pregnancy. And when we don't get pregnant, the lining comes out as a form of period. 10 to 20% of women, and I think more than 50% of PCOS patients, have cells similar to the lining of the uterus outside of the uterus. It could be around the tubes, ovaries, on the bladder, on the rectum. It could be all the way up in the diaphragm. It could, sometimes we find ectopic tissues in the lung or the brain. So this tissue is highly inflammatory. In a normal menstrual cycle, as one hypothesis is that as the lining is getting shed, the endometrial lining during the period is getting shed, some of those cells come back into the tube and out into the pelvis. So if you have a uterus attached to 2 tubes and 2 ovaries, some of the tissue that's supposed to come out, some of that endometrial tissue actually goes up the tubes and into the pelvic cavity, right? In a normal immune system, which we have to talk about our immune system because I think it plays a huge role with endometriosis, a normal immune system will get rid of those cells. But in endometriosis patients, their immune system actually takes these cells, sticks it to the wall of the pelvis, the bladder, the rectum, whatever it is, diaphragm, abdominal wall, pelvic wall. And these implants start an inflammatory process. They start expressing their own aromatase enzyme, and they start making their own estrogen because they need estrogen to grow. They grab onto the vessels, they start growing, and then they make their own nerve fibers. And these are the pain fibers that can get inflamed, especially around our menstrual cycle time. And these are patients who basically complain of period pain, bloating, recurrent bladder infections that are not really bladder infection, pain with sex, with deep penetration, pain with bowel movement, chronic pelvic pain, bloating. They're constantly complaining of some discomfort. These are patients who sometimes they need to be picked up from school because their period pains are so bad. Wow. Sometimes they end up in the emergency room or urgent care because their periods are so bad. These are women who change their social schedule around their periods. They plan their vacations around their periods. They plan everything around their periods, and it becomes completely disruptive. Again, it takes 9 to 11 years for these women to get diagnosed in this country. On average, they see 5 to 10 doctors. They bounce from doctor to doctor, and every time they're told there's nothing wrong with them.
What's the average age of diagnosis for
32.
32.
Think about it, though. By 32, they've had, 15 years of trauma with their pain. I had a patient from Florida last month. She was coming to see me, and she said she gets her period on the day of her travel. She gets on the plane, and as the plane takes off, her painful periods were so bad that she had to lay in the middle of the aisle. They almost turned the plane back. And they told her, they're like, we can go back and land again. And she's like, no. I have endometriosis. I'm going to see a doctor who will diagnose me. Don't turn this plane back. Think about it. A woman, she's 20, a 20-year-old who's seen 10 doctors in Florida. They all told her there's nothing wrong with her. Her pain is so bad that the plane wants to return to the airport.
Wow.
And yet these doctors are telling her there's nothing wrong with her.
Are the risk factors similar compared to PCOS, or are they different?
No, they're completely different.
Interesting.
So endometriosis is a highly inflammatory, going back to this issue. So as these implants grow and secrete estrogen, and every month there's more of them coming and attacking the pelvis, it causes a highly inflammatory environment in the pelvis that can eventually cause a leaky gut. They get small intestinal bacterial overgrowth. When they eat, they get super bloated. They're tired. They're anxious. They have brain fog because of the inflammation, because these implants are progesterone resistant. They're estrogen dominant. All of this affects their mental health. And one thing that happens, because these patients are not diagnosed, and because they bounce from doctor to doctor, doctor to doctor, and years go by before they get diagnosed, this chronic inflammation destroys their egg count and quality, especially if they have endometriomas. These are endometriosis inside the ovary that can be damaging to the ovarian reserve. But then another thing happens, because these nerve fibers are firing, and these patients experience pain first few days before their period, and then few days before their period, few days after, then 7 days before their period, 7 days after, and then eventually it's a chronic pelvic pain. What happens is the central nervous system, our brain, gets rewired to that pain and starts magnifying it. We call it central sensitization. So the brain basically amplifies that pain. So if that pain, you and I would perceive that pain as 2 out of 10, an endometriosis brain will perceive that pain 10 out of 10. That's why they end up in the emergency room. Wow. That's why they end up in bed and they can't move for 3 days. That's why they're vomiting. That's why they're passing out. I mean, it's so bad. And I always say, and this chronic inflammation can cause scarring of their tubes, destroy their egg reserve, cause them to have bowel issues, and eventually they get anxiety, depression, motivation issues, all of it. Some of them become suicidal. That's how bad the pain is. And what do they get? They go to the doctor, and the doctor's like, there's nothing wrong with you. Here's some Percocet. Here's some Norco. Okay. I believe that a lot of these young women, I have so many patients. I had a patient who used to take 30 Vicodins a day when she was pregnant, and she lost that pregnancy. Wow. But her underlying condition was undiagnosed endometriosis for years. That's how she became addicted to Vicodin. And, it's so sad. And I always say, if you had a condition, if men had a condition that would put them in bed once a month, rolled in bed, vomiting from pain, and if they ended up in the ER once a month or an urgent care, if someone would give them prescription medication for their pain, if their scrotum would scar down, if their sperm count would go down, if their penis would hurt every time they had sex, or every time they had an erection, they would get stabbing pain in their penis, if they were always bloated, if they always had chronic pelvic pain, if they were anxious and depressed, do you think 90% of these patients would go undiagnosed in life? Do you think 90% of these patients would be told by a doctor that there's nothing wrong with them?
No, I think we'd probably have like monthly societal shutdowns, yes. Almost like monthly siestas for men.
I want to cry for these patients.
We're big babies.
No, but it's not about being babies. Women are not babies. These are painful lesions. This can take your breath away. These nerve pains are so, I don't know if you've ever had nerve pain, it can be debilitating. But to get dismissed time after time after time, year after year after year after year. I had a Canadian patient once who came to see me, the most beautiful woman, and I live in LA. Everyone's beautiful in LA. To me, everyone's beautiful. This woman was one of the most beautiful women I've ever met in my life. I met her at 30. Her egg count was 0.
Wow.
9 years of bouncing doctor to doctor in Canada, and she was told there was nothing wrong with her.
At 30, man.
At 30. You want to cry. If you spend a day with me in my office, I cry with my patients. My physician assistants cry with me. My scribe who's in the room with me cries with me, because it's so frustrating to keep listening to these patients. And over and over again, whether it's PCOS endo or PCOS and endo together, the first thing these patients tell me, the very first thing, it never fails, the first thing they say is, I feel validated. That's all they want. They get on a plane to come and see me. They already know. They know because they can go on ChatGPT, they can go on Google, but you still need a doctor to validate you and say, let me help you. Give me your hand. Let me lift you up. Let me help you. Let me change your life. This is not how life is supposed to be. You are not supposed to be in pain every single day. This is not okay. You are not crazy. And let me tell you something for the record. When a woman, I don't know about men, but when a woman tells you something's wrong, 100% of the time something's wrong. They're never wrong. When they say something's wrong, take him seriously.
Amen. I agree with you. So what is the treatment? Does endometriosis necessitate surgical treatment, or are there...
Not necessarily. If you catch these patients early, right, and they don't have fertility issues, and you're not trying to backpedal, one thing you can do is, as we talked about, these implants are estrogen dominant, but they can be progesterone resistant. However, progesterone slows their growth. So you can do IUDs, progesterone IUDs, like Kyleena IUD or Mirena IUD. I love those, starting with those. You can start low-dose birth control pills. You can do progesterone-only birth control pills. I don't like the shots because sometimes they can have weight issues, and a lot of my patients also have PCOS with their endo, so I don't want to do anything to cause any metabolic issues with them. But the gold standard treatment for someone, especially with painful sex, patients who have painful sex with deep penetration, patients who have 10 out of 10 pain, debilitating pain, and they have failed birth control or other hormonal suppression, gold standard is still laparoscopic surgery. The issue is, and I trained at an amazing program, so I was very skilled surgically when I left my program, but not all OB-GYN programs right now. You know, the problem with OB-GYN is you do OB and GYN, and OB is very time consuming. I love my OB patients, but they're the ones who wake you up in the middle of the night. You have to wake up, go deliver them, you know, stay up for like 36 hours with them. It can be very time consuming, and it can cause a lot of burnout in gynecologists. So when you've been up all night delivering babies and you're exhausted and you haven't slept well, and the nurse woke you up 7 times during the night, and you go in the morning and you have 50 patients on your schedule with insurance that you need to see, and you have these endo and PCOS patients who each need an hour, 45 minutes of counseling. So what happens to these patients? They get dismissed, right? Doctors don't have time to... The system is not built for doctors to give the highest level of care. How about that? Yeah. And when it comes to surgery, unfortunately, because a lot of doctors focus on the OB part, the surgical skill can be different. And that's why I always say, if you separate the two fields, then the gynecologist can focus on laparoscopic surgery. Endometriosis surgery can be very tricky. A lot of these implants sometimes sit right on the ureter, the tubes that empty our kidneys, and you literally have to grab them from above the ureter and cut them. So if you're not trained laparoscopically, and if you're not an amazing surgeon, you might cause more damage and more harm to these patients, A. And 2, one thing I've noticed over the years is if you give 100 laparoscopes to 100 gynecologists, 50% of the time they wake the patient up and they say, I didn't find anything.
Wow. 50% of the time? Mm-hmm. Man.
Maybe 40 to 50% of the time. And I see that all the time.
Is surgery the end of the line when all other available options have been exhausted?
Yes.
Okay, so
or for someone who has tried for pregnancy and can't get pregnant, for someone who can't have sex. These patients sometimes are like, you want me to get pregnant? I can't have sex.
Wow.
Do you know what I'm saying? So I go in, and a lot of times these endometriosis implants sit on the uterosacral ligaments, these ligaments that hold the cervix and uterus up, and you see them. The problem is there's stromal endometriosis during surgery. Stromal endometriosis, typically when you think of endometriosis implants, these little growths in the pelvis, they have this purple-looking blood-filled, like they're 2 to 3 millimeters. Sometimes they're bigger. They're more than 5 millimeters. They're deeply infiltrating. So they have a very specific look to them. Those don't get missed. But the stromal type, which is missing the glandular part that bleeds, and it has the stromal part of the endometrial tissue, those tend to look like these clear, white little ulcers almost, or sometimes these white lines inside the pelvis. And those, unless you've seen at least hundreds of times, if you've seen these, you will recognize them. But you need to go so close to be able to see them, because if you just put a scope and quickly look, 1,000% you're going to miss these. And these stromal endometriosis, in my opinion, tend to be highly inflammatory. They're more progesterone resistant, so they're the implants that you really have to go after and cut them out. And these patients complain of just a lot of inflammation and bloating and pain. And when you cut these implants out, you give, it's a life-changing, literally life life-changing for these patients. So someone who's had 15 years, 20 years of pain. I'm a very good surgeon. I take him to surgery. I do laparoscopic surgery. I resect. You can't burn these lesions. You have to literally grab them and cut them one by one. It takes a long time. Sometimes I did one on Friday. I think she had 30 lesions. So one by one, you have to go. You can't ignore a single one of them. Wow. And the truth of surgery, and my personal observation over the years, has been that endometriosis needs suppression. So what do I mean? When you have someone with colon cancer and you go in and you resect their bowel and remove the cancer, you never tell him, all right, sir, I'll see you in 6 months. He's going to come back with cancer everywhere. You have to give him chemotherapy. So endometriosis obviously is not cancer, but you have to suppress. You have to suppress after surgery. So one thing that I love to do after my laparoscopic surgeries, while the patient is under, I put a progestin IUD in. And that way I can, control and prevent them. Otherwise, a lot of times in 6 months to 2 years, these patients bounce back. I saw a patient once from Northern California, and she told me her chief complaint when she walked in was, I'm here for my 12th laparoscopic surgery. And I was like, excuse me? She's like, yeah, I go once a year for my endometriosis surgery. I'm like, what? No. So, these are patients who bounce back because they're not getting that suppression.
Is there ever a situation where they might naturally reverse? Like the immune system? Stupid question maybe, but like...
No, and I don't want to give that message here because it progresses as you age. That's why the average age is 32, because either these patients have bounced from doctor to doctor until one person says, you have endometriosis, let me fix it. Or they get to a point that they have fertility issues and they end up in a fertility clinic. But by then, it's too late. Either their ovarian reserve is gone, their tubes are blocked, they have scarring everywhere in their pelvis. And what do you do? When I get patients who are 38 with disaster endometriosis symptoms, I'm like, just go do IVF.
What are the most common risk factors for endometriosis?
I think family history increases your risk. I think PCOS, in my opinion, is a risk factor. I don't know if it's chicken or the egg, but I think PCOS patients, because they get irregular periods and they can have heavy periods, they might have more overflow into the tubes, into the pelvis. I think their immune system, is a huge, I think if you study endometriosis, you have to study the immune system because they're directly linked. And endometriosis is an autoimmune condition because your own tissue is attacking your own body is attacking your own tissue. So whenever I have an endometriosis patient, I look for other autoimmune disorders in them. I do a full autoimmune panel because whenever you have one autoimmune condition, you have a 33% chance of having another one. So I don't want to miss another one because obesity would be anything that increases the inflammation, high inflammatory diet, obesity,
obesity, inflammation, insulin resistance is like sort of a modern day medical Rosetta Stone. Through the lens of insulin resistance, like so many.
Everything. Yeah. That's why these GLP-1s exploded, because the GLP-1s address the insulin resistant that patients have been ignoring for many years. Man,
it's so true. And everybody in LA now is on one of these GLP-1 drugs for vanity, it's just like, it's crazy.
You know what? For PCOS, and it's heartbreaking when you see these patients. Literally, I had a family member of mine walk into my house. She was skin and bone, and she was on a very high dose of GLP-1. I wanted to vomit when I saw her. Wow. And people are definitely abusing these medications. But I'm talking about a patient with morbid obesity who's failed. And these are patients who used to end up having gastric bypass surgeries and doing gastric sleeves and everything else. Now, I have patients who've lost like 150 pounds with me, 200 pounds, because I've been doing this since 2014. So I have patients who've lost that much. And in the olden days, they would have had to go under the knife. And, gastric bypass, gastric sleeve, not majority, I don't know the exact percentages, but I can easily say that 50% of them fail after 5 years. So then what do you do with these patients who've already had this gastric bypass or from sleeve, you can go to bypass, but from bypass, where do you go? So it's very, it's been a game changer for this subgroup of patients. And when I see them come to my office, having lost 100 pounds, they have their confidence back. They feel good. Their mood is better. Their periods are regular. They're getting pregnant. I mean, it's heartwarming. It really is heartwarming.
So if you had to send one, message to healthcare practitioners who may be listening, like, I feel like a lot of women tend to be underserved in general as a demographic. I mean, there's so little there can be so few resources and research in general, on these topics.
50% of our counties don't have an OB-GYN in this country. 50%.
That's crazy.
Yeah. So there's no access. Thank God for these platforms, telehealth platforms. But, sorry, I didn't mean to cut your question. What was your question?
No, I mean, how do we change the system?
So that's why I started my SheMD podcast, honestly, because one thing I realized after 30 years in this healthcare system that's run by insurance companies, dictated by insurance companies, how many patients, I was talking to a friend of mine who's a gynecologist in San Francisco. She called me, she's like, how do you pay your bills? How are you sustaining your practice? Can you tell me? Because we are a group of OB-GYNs and we're going bankrupt. We're working 14-hour days and we cannot pay our overhead. Why? Because a doctor, in-network doctor with insurance is getting paid less than a plumber who comes to your house to fix your plumbing. And that's the reality of our healthcare system. Now, when you get to women's health, in this healthcare system, women are considered crazy until proven otherwise because nobody has time for them, because the system has been set up and the poor doctors don't have time to pay attention and diagnose these women correctly. So there's a time issue. It's the insurance companies running it. It's the fact that women get dismissed. It's the fact that from a very young age, we're told that painful periods are normal, that, everything you feel is in your head. You're probably crazy. I'm a women's health advocate. I've been advocating for women for years. I still go to meetings. And when I had a meeting a big meeting that I was in, and I was the only woman there, and we had someone stealing from us, and I confronted him during that meeting. The following meeting, when I went back to that meeting, the first thing he said in front of everyone, a room full of men, I walked in, he said, I hope you're not PMSing today.
Wow.
So women are still treated. In my head, I'm like, you're stealing. I'm being honest, but I'm the crazy one in this room. So that's how women get treated. So what is my message? How do we fix this system? Educate our women. Yeah. That's the only way. And that's why, as busy as I was, I started a podcast with my partner, Mary Alice Haney. It's called SheMD. And basically, we give information. Everything I do in my office, everything we talked about right now with PCOS, with endometriosis, whether it's menopause, vaginal dryness, brain health, your ApoB levels, fibroids, yeast infection, bladder infection, whatever it is. We talk about it episode per episode, and I give women the information they need, literally, to take notes, to take it to your appointment. Why? Because if you educate, in order to self-advocate for yourself, you have to be educated. So listen to your podcast, to my podcast, listen to these podcasts, educate yourself, go on ChatGPT. I don't care how you get educated. But be informed. So if you have 10 minutes with your doctor, make sure you go in already well informed so you take advantage of that 10 minutes. Ask for a pelvic ultrasound. Calculate your lifetime risk of breast cancer. If it's high, ask for that MRI imaging. Ask for your egg count. Anti-Mullerian hormone it shows your ovarian reserve. It doesn't mean you're going to get pregnant or not, but every 18-year-old needs to know her ovarian reserve, if you ask me, because endometriosis doesn't get diagnosed. Know what that ovarian reserve is. Ask for your hormone test. Ask for a pelvic ultrasound. You have to be your own health advocate, and that's the only way to fix this system. Because if you empower women to advocate for themselves, then doctors will stop dismissing them.
Beautifully put. For anybody who's listening to this who might feel as though they are at the end of their rope, what do you have to say to them?
If you think something's wrong, 1,000% something's wrong. If you are being dismissed by your healthcare physician, nurse practitioner, physician assistant, it doesn't matter. Go listen to these podcasts. and go until you find an expert. If you think, for example, if you listen to this podcast and you're like, I swear I have all these symptoms, I have PCOS, go search PCOS expert near me. Listen to all the PCOS podcasts that you can. Be informed. Go to your doctor. If your doctor says you don't have a cyst on your ultrasound, say, doctor, no, I don't have to have a cyst on my ultrasound. It all comes down to education and self-advocacy. I cannot say it enough.
Now,
I cannot say it enough.
Is every OB-GYN necessarily an expert in PCOS?
No, but the patient can be. You can be. Listen, I have a small mass under my scapula that causes me a lot of pain, but I was my own health advocate. I question, I still go when I get my treatment. I'm like, is this the right treatment? Is this the right dose? And, I go to different doctors. I get different opinions. I research it. So, and it's not because I'm a doctor. I know nothing about shoulders. Do you know what I'm saying? But I educated myself on it. So when my doctor gives me information, I'm already there. He just adds to it for me. So it doesn't matter where you are. Even for men, you have to be able to advocate for yourself and for your daughters and
Amen.
For your sisters and for your mom.
Hear, hear. Well, I've got one last question for you, but before we get to that, where can people find you on social media? You're a powerhouse. This was so fun.
I'm glad you had me here.
Yeah, so fun. You got to come back.
You will see how much of an impact this will have on your listeners, on moms who have daughters suffering, on women who are listening to you and that have been dismissed for years. I want them to know that, what they feel is real. It really is. And where they can find me on SheMD podcast. That's my baby. It's everything I do. If you think you have PCOS, I would say go on OVII.com, take the quiz, see if you have the likelihood of having PCOS, take the supplement, listen to all the PCOS and endometriosis podcasts that you can on SheMD. But SheMD podcast is my baby, and all the information that I share is always on that.
Love it. Well, I love my female listeners, and they know that I've got their backs. So I hope that this episode was helpful to all y'all out there. The last question that gets asked everybody on the show: what does living a genius life mean to you?
I've had breast cancer, and I survived it. And I learned a big lesson from that because I was always running. And when you have a diagnosis like cancer, it's like a slap in the face. And for me is to, I'm not there yet, but I'm trying to get there, is to try to take advantage of every single day. Every single day. That even this morning, I woke up, I looked outside and I could hear the birds and my husband was laying next to me. The first thing I told myself is, I'm so lucky. I'm so lucky that I get to wake up healthy with no pain. I have my loved one, my children at home, and I try to appreciate what I have and think positive and don't look at the negatives. And really, for me, my family comes first. My husband, I have the nicest husband on the planet. He's my first boyfriend ever. And I've only been with him since I was 20, and we're together now 35 years. And just being with him has been an amazing life, but I've learned to even appreciate him even more. And just, hold my children close to my heart. For me, a genius life is that for me, to be healthy and enjoy my beautiful family.
I love it. That's beautiful. Thank you, Thais.
Thank you for having me.
Thank you guys for listening. Share this episode with people in your life that you think may benefit from it. Sending love to you all out there, wherever you happen to be, and I will catch you on the next episode. Peace. Hey, if you liked that video, you need to check out this one here, and I'll see you there.